Hello, and welcome to Ethics and Moral Problems. My name is Dr. Stephen Bujno. This is a lecture on end-of-life care from a philosophical perspective. So we'll look at some of the contrasts and the nuanced understandings of it, and then the considerations that we can glean from those. Now, it's an odd thing to say that there is a certain value to one's mortality, but the reality is that the realization of mortality, as they say, like taxes, are one of the two certainties that we can count on in life. But the fact of it is that the reason that there is an end to this life gives us a sense that there is something to be achieved prior to the termination of ourselves here on the earth. So that means that death does have meaning. If life has meaning, so does death. So there's a purpose and there's a meaning to this. This has been, how do you want to say, thought about throughout religious traditions. It's been looked at from secular philosophical traditions. It's been looked at through psychoanalytic traditions. And speaking of psychoanalytic traditions, Freud's Eros and Thanatos, the life and the death principles. With the life principle, the Eros, you see this sense of social cooperation that we all have with each other. And it was all those things that are directed towards survival. So, anything that has to do or constitutes pleasure and reproduction and such. And then with the Thanatos, those things which we channel outward. So anything that forms from aggression or trauma and such. So these things then are those drives that play out in life. It's an obvious thing to state, but philosophy always studies the obvious thing because most people just skip over that, is that death is like birth. Now we'll talk about whether or not death can be chosen when we get to the second part of the slide on euthanasia, but nobody chooses their birth. We have no memories of those, and we don't personally experience death, except for, say, a few people perhaps that have, come back from death. We don't experience that twice. So the reality is that all of this constitutes what we consider the human person. And it matters very little whether a person has a theistic or a secular point of view on this. We're all trying to make sense of this, even from a purely secular point of view. Think of existentialism. You have the myth of Sisyphus, where a person was condemned for all eternity to push a boulder up the hill, and then at the top of the hill, the boulder fell back down, and they had to push it up again. So it's sort of like in life, how we just sort of go through the rigmarole, and we never really get a chance to try to determine what is the meaning to all this, because it appears absurd. I push it up, it comes back down. So the existentialists say, but the meaning is not found in the goal of it. The meaning is found in the struggle, and that particular is what constitutes some meaning for the human person. Theistic points of view, it would be rather crass to simply say it's only because of some future after-death reward. Most monotheistic religions would never express something like that. But the fact that there is something transcendent in the human person does give meaning to the course of life on the here and now, we can say. So let's say that we have no memory of our birth. We're told about it. And again, except for the scant few who might actually have come back after being pronounced clinically dead, death is also something that we don't have as a personal experience. Now, we experience other people's birth and we experience other people's death, but that's a little bit different. And something that is unique to the human person is the fact that we do care for the dying, and this speaks to who we are as individuals. Now, it's true that animal behaviorists and biologists will say that other species perhaps have death rituals, lemurs, dolphins among them. But they're nothing like we do. They don't bury their dead, and we'd have to be careful we're not projecting our own intuitions on what they're experiencing from our own experiences. In other words, it could simply be a response. But what's important here is that all of the parties involved become part of this experience. So for those medical professionals, nurses and doctors, the patients themselves that are going through the process of death, and the caregivers who are walking along with them, sort of the in-between within the patients or between the patients and the professionals. And you'll find this play out in hospice care, which is really comfort care for those that are terminally ill, or from palliative care, which doesn't need to be for terminally ill. That could be for something chronic, but there stresses any help or aid of those that have life-limiting illnesses and such. So the reality is that pain and suffering are always internal for the patient. It could be that the caregiver and the professional has some sort of understanding of what's going through and therefore can relate. but at the time it's internal for the patient and it's external for the professional and the caregiver. So what brings these two together is what we would call empathy. Empathy is distinguished from sympathy. Sympathy is not just simply a realization that the person's suffering, but this is an entering into. Here I have as the meeting of two eyes. But we could even say, sort of like in the terms of Edith Stein, it's the 0 point of orientation between the two people. So it's the absolute interiorizing of the other individual's needs and such. So this could have wear and tear on the professional and certainly on the caregiver. So we have some sort of way to compartmentalize this at times just so that we can continue functioning. But we don't want to be so robotic that we don't enter into the lives of the people that are being cared for. That would make it a very external thing entirely. Now, the needs of those that are dying, we're not here to talk about the physical needs that will be given both by the professional and the caregiver. But when they have done polls and reviews on individuals who are experiencing death or entering into, what they find is that there are at least four major categories, if you want to say, that they're trying to satisfy. Everybody starts a life review. Did I do well with what I've had in front of me? This would include everything from adulation for the good things that are accomplished, love, marriage, and children and such, achievements, but also regrets, which are not a terrible thing because we can't always achieve the ideals that we set out to have. And it's a time to say goodbye if that type of death allows such a thing. Saying goodbye, which could help resolve some things and also give us last moments to say some things that perhaps we were a little reluctant to say otherwise. This can be a very intimate moment. And also resolving unfinished business. That plays out in many different ways that individuals have, and that's quite personal, but nonetheless, it's a time to take care of things while there is still time to take care of things. And for those that have a theistic background, it's a peace with their God. It's not just simply to get all things right before an individual dies, but to make some good on the resolutions and the hopes that one had, and to simply to do nothing else than to seek the peace that the individual may or may not have had earlier in their life. So all of these things, you can see, they border on two dichotomies. One, they can be very introspective, but they're also relational. So, death is always something that's done in community. That's odd for us today because we die in the hospital, and the bodies for viewing are in a funeral home. It used to be that people died in the home, and the parlor is literally what that room was in a home for people to come and view the bodies. So it was a much more intimate experience. But that being said, there was a poem by John Donne, For Whom the Bell Tolls, based on the concept that when a village, someone died in a village, a bell would toll, and people would wonder, who is this bell tolling for? So John Donne writes, and I'm just paraphrasing from memory here, he says, "No man is an island, entire of himself. Every man is a part of the continent, a piece of the main." And this is an important part. He says, "Every man's death diminishes me, for I am involved in mankind. Therefore send not to ask for whom the bell tolls, it tolls for thee." So it literally means that we are participating in other people's death because we're not separate from them. Which means that those that are caring for those who are dying could talk about a different type of competency. And here we'll talk about a narrative competency. In other words, there's something that is purely symmetric between the patient, the caregiver, and the professional, where there's an active listening, and there enters a shared understanding of meaning. So the patient is treated and understood as a vibrant soul. It's just a different way to approach that I am not just here to clinically do X, Y, and Z, but I'm entering into intimately with an individual. Now, when we talk about ontology, this is the metaphysics, this is the idea of being itself and the personhood as being. There's an ontological notion of death that we already kind of hinted on as far as the birth and death memory experience dichotomy. And the reality is unlike life, which always comes from life, so the ovum and the sperm are alive, they fertilize, become the oocyte and then the embryo, so life is a continuous process. But death there is nothing like that we could say biologically. So there's no continuous biological life after death. What we have here is we have the notion, and this is what it comes down to: at what point are we no longer calling this individual in front of us a person? So once death has been pronounced, we'll talk about what that means in a second, we no longer say that is Uncle John or such. And that's a real, how do you want to say, existential moment for all of us. That at one moment in this body was a person, and now after this moment, this is no longer a person. But it's not clear here exactly how we come to that understanding of what constitutes this person, or therefore the lack of. So we'll accept and say, quite frankly, because it is true, that death is a process. Now, I want to watch throwing it into these two dichotomies, because on one side, somebody might say, is death the dissolution of the organism as a whole? Or is death simply the whole organism, that has a dissolution? So like there's, in other words, there's some biological functions that can continue. If we try to talk about death of the organism as a whole, here you're going to have to make a side with either the materialist understanding that there is nothing immaterial outside of what's here. Consciousness is some phenomenon that appears basically from the brain, or from a theistic point of view, where there's a transcendent soul-like aspect of the human person, and then when exactly that soul no longer is present with the composite, as a composite being, therefore it's death. Now, the reason why this is important to come through this argument is because organ donation is on the line. We'll have to talk about death in terms of brain death. There's cardio death, and there's pulmonary death, and it used to be that cardiopulmonary were the indicators. Now, I won't list them here, but various organs will only be, how do you want to say, viable, depending on whether or not there's still circulation. And some vital organs simply cannot be removed after the individual's dead. But there's another catch to that. I'll come up in a second. So if we talk about whole brain death, which is probably the ethical stance that the majority of professionals would hold to, that's probably a dangerous thing to say, but nonetheless, they'll do a test through some painful stimuli. So they're just trying to get a reflex to understand if there's anything within the brain stem. So this would be whole brain death rather than simply like higher brain death. It's not just a loss of memory and such. This is that there's at least the sense that there's no consciousness. It would be followed by apnea tests, consecutive EEGs, typically over 2 days. But, and there is the but here, it doesn't solve the issue. And again, the definition of death matters because it's going to have some sort of play on the outcome of whether or not organs and which organs can be retrieved and, let's say, harvested. So the dead donor rule, now, this means that there can only be retrieval of organs that do not cause death. But people have, without me going into some extensive explanations, people have been in respiratory death, because you could artificially maintain respiratory and cardio function. You can't artificially maintain brain function. So if a person is determined brain dead, then the cardiopulmonary will be artificially maintained until organs can be retrieved, let's say harvested. But there's a lot of gray area here, which would be a little bit too much to get into through an asynchronous video like this, but nonetheless. So the dead donor rules are somewhat controversial because they could be limiting on what organs and when those organs can be harvested and whether or not they remain viable. So here we are again. You're going to have some ethical stance on what constitutes the human person, and then what ethic is basically going to be applied to that. Now, the reason why I bring this up, and I only mention this because it is quite rare, but there have been instances where individuals have been declared entirely brain dead, have spontaneously revived, and when they did revive, they had recollection of what was going on in the room. Now, I don't mean they were floating above their beds and were able to see what was going on. They heard their mother speaking, or they heard other people speaking, and they gave enough evidence that everybody was quite convinced that this person was simply declared whole brain dead by error. But that means that there could be a form of consciousness that lies in areas of the brain that could not have been um, measured to determine whether or not there is still, some element of consciousness, and those being the hypothalamus and pituitary gland. So, because this would really and severely strictly limit organ donation, some ethicists have attempted to make a case that the hypothalamus and pituitary gland are not necessarily part of the brain. Now, if that seems particularly odd, definitions are always important. So if people want to change a practice of something or an understanding of something, the way to do it is to change the definition. So if you do change the definition of what constitutes the brain, then you could say that even when individuals perhaps might have some consciousness that we cannot measure in those particular areas, it could still constitute whole brain death because they themselves are not part of the brain. I'm going to leave it there rather than try to give some deeper, more comprehensive understanding of it. But there's plenty there that an individual can look up if you are interested in doing some research. And then finally on this slide, what ethical system is being used to evaluate all of this? You could see how deontology is going to come up with this. What rule are we talking about for brain death? Utilitarian, you're going to see probably lean much more towards harvesting organs, even why there's some respiration, provided that the condition is irreversible and other things. And you're going to see probably even different issues with principalism, but that's a whole other story because we're not going to be able to really determine what constitutes justice in this case and what constitutes no harm. So anyway, we'll leave it there and we'll move on to the last slide of this lecture, where we're going to look at the ethics of withdrawing care. So here we're going to be talking about end-of-life issues and how it relates strictly and philosophically to human dignity. Now, we are in a fortunate period of time. Of course, I'm imagining every particular age has thought that, been glad for the technological advances. So let's just simply state that technology is the manipulation of anything in nature for the use of the human person. And this would include anything from a straw to a toilet to cell phones to life-sustaining equipment. So what we have seen over the course of time is that many illnesses that were terminal, particularly maybe diabetes and some other types of infections that can be treated now, are now chronic diseases. HIV and AIDS in the 1980s were terminal conditions, and now they're still serious conditions, but they're chronic conditions. And it's the hope that in the future this would be what we say of many of the cancers. So perhaps a person who today would have been diagnosed and have maybe a 5-7 year survival chance, person could say that under normal conditions you should have the remainder of your years, although you will have this chronic condition that you'll have to experience. Now, over the course of time, life expectancy has of course jumped. So we're into the late 70s now, and of course people live into their 90s. If a person was born in the 1920s, the life expectancy might have been 50 years or 55 years or so. That doesn't mean that that was old age. Life expectancy is often was skewed because of infant mortality or even maternal mortalities. So those all figured into the averages. For the most part, if a person did make it through their childhood, outside of any other chronic illness or terminal illness that we would get today, they could be expected to live into their 60s and 70s and such. So life expectancy has increased, but the HLE is health life expectancy years. So what they have found is that people are living longer. I mean, to put it bluntly, people are living longer, but not better. So like the poor outcomes of people in their 70s and 80s are about the same as the poor outcomes of people in their 70s and the 80s pre-World War II. So because of our technology and our wonderful advances in medicine, people can expect to live longer. But we haven't really found overall that people are having a quality of life that matches those extra 15 years. We all know the YouTube videos of a grandmother or such who's on the parallel bars. But those are really the anomalies. If you go to any nursing home, you'll see what an 85 and 90-year-old looks like. So nonetheless, what it means then, if we're talking about withdrawing care and such, or withholding care, we're going to have some sort of proportion to, weigh and determine between the benefits and the burdens. So we'll look at things as far as futility in terms of medical possibilities, probability, respect for autonomy. They're all aspects that we should consider. Futility is not an easy word to define. We started out, at least this course in part, talking about the first act of the mind and how the clarity and lack of ambiguity in a term is essential, so there's no equivocation. So when one person says it's futile, we're not exactly sure what that means. So we could at least say that if we're talking about physiological futility, this is somewhat objective. In other words, whatever the procedure or the remedy that is going to be sought will have no chance for continued life of the individual. So that's objective and quite frankly, perhaps maybe what we sort of mean in the back of our heads by it's futile. But there's also quantitative futility, where here we're, if you want to put a figure to it, say less than 5% or less than 1% chance. So there's, we could do something here, but the opportunity for any sort of benefit to come out of this is so low that even though there is a chance, we're still going to consider it futile. As far as qualitative futility, this is very subjective. So it could simply be that because of the family physician or the patient, they see that there is intervention that's possible and that there even will remain life on the other side of the intervention, but that's not how I intend to live, nor is it how I would like to live. It could be a reduction in cognitive functions, mobility, and such. Nonetheless, these are just three different ways to determine futility, and the reality is there's no consensus on these per se. So this brings us then, if a person does hit one of these levels of futility, what is the distinction between allowing or causing one to die? So I'm going to refer you back to how you determine the moral object, like in other words, what is the thing we're doing? Remember, the moral object is the what, the intention is the why, and the circumstances are the who, what, when, and where. So the reality, whether it's euthanasia, causing someone to die, or accepting the finality of life, allowing one to die, we all agree that the intention is the same. It's to end suffering. So if you're doing this from a utilitarian point of view and your goal is to end suffering, you'll see no real distinction between these. If you're doing this from a deontological view or from some other form, virtue, you're going to see different moral objects, accepting finality or euthanasia. I don't want to put a chart up, but I do want to at least mention that there are four combinations that can be made, two that are depending on the will, and then two on how it's done, the form of it. So the reality is that if euthanasia is ever done involuntarily, it's going to be homicide. If it's done voluntary but passive, this would be perhaps starving oneself to death, or you could think of pulling out feeding tubes, something like that. I'm not trying to be specific, just give a general idea. But when we talk about voluntary active, this is what we will call physician-assisted suicide. Okay? As far as the American Medical Association's position on this, it's nuanced, so I'll leave it without going into any depth. But as far as the nursing code, they still do hold that a nurse may never aid nor abandon their patients, so they could be there during it, but they also cannot participate. Now, the reality here is that we're going to have to ask ourselves, first off, if we're just going to work from principlism, here we're going to see the conflicting principles arise. If we stress autonomy, the autonomy of the individual, perhaps they want this. So then, to be respected, it should be carried out. If we're going to look at beneficence or maleficence, we're going to have to say, if we're going to do no harm, or we're going to try to do good, we're going to have to come up and say, what exactly is harm? Is it harm keeping the person alive when they don't? Is it good allowing them to die even when they don't want to? And as far as justice, to give another due, it doesn't get us out of the woods. So even things that are promoted as practical applications in principlism, we're sort of stuck yet. You're going to need more to help here. Because the reality is that if you're going to try to say, is physician-assisted suicide medical aid, or is it just assistance? Is medical aid determined only by treatment, and is assistance, helping and control? So it's important that we don't just try to repeat various principles or calculations that come from ethical systems in this regard. This is going to take, in other words, there's no rubric or system that you could simply put this in as an algorithm and then shake out the answer. This is going to take, at the very least, the virtue of prudence, what to do in the right situation, and it'll take some deliberation, the very least, we'll say. Now, the concerns. What would be the safeguards for individuals who are seeking physician-assisted suicide? Now, oftentimes, the slippery slope is brought up in this case, and I want just to recall that the slippery slope is not always a fallacy. It's only a fallacy when the causal links differ. But as long as the links between the various ends that are being chose, the goals, then it is a slippery slope, but it's not a fallacy. So you could do some research on this, but of the research that at least has been offered, it shows that more often than we care to know, physicians do ignore guidelines. It could be upwards of 30% or such. We're going to also ask who made the request. If the person is not competent at this point, let's say that they're even non-responsive, and they don't have any living will and they don't have any directives, it comes from the family, you can never rule out ulterior motives. So the nurses will have to read the room. They're going to have to figure out if there's no medical power of attorney that's been assigned. How's the ethical team going to work through all of this? The other thing is that, let's just say in the United States, particularly in Oregon, if a person did want to end their own life through physician-assisted suicide, the physician is not going to simply do this. The physician is going to give the means for the patient to do it. And there are certain conditions. The one is that you had to be a resident for an amount of time. You can't simply move there because your state does not allow it, but Oregon does. You need to have a terminal illness with, I think it's a prognosis of less than 6 months. There's going to be at least 2 oral requests and 1 written request. There's going to be some sort of psych eval that can at least rule out any major depression. And once that the means is given, there's still going to be like a 15-day waiting period or such. Coincidentally, there's been a substantial minority of individuals who have gone through this that had never ended up committing suicide, or euthanasia, we'll say, which is just something to reflect on, I guess, at the very least. The other thing is what about chronic illness? So, those criteria are somewhat flexible and somewhat arbitrary. In other words, if a person is going to make the claim that they have a right to die, and we hear that, then their right to die should not be predicated on what a state lays out as far as the 6-month or less survival time and a terminal illness. So why not chronic illness? Other countries, forget about the United States for a second, like Belgium, I think back in 2013 there was 45-year-old twins, and they were deaf, and for whatever disease they had, they were going blind. So they didn't want to live as deaf and blind. So even a brother trying to talk them out of them, and family and such, they went out and bought new clothing, had a little get-together, and then simply took their own lives. So that's just one example, but their issue would be there was nothing terminal with their blindness nor their deafness, but they didn't want to live like that. And as far as age, too, at least in the Netherlands, an individual as young as 12 can accept voluntary active euthanasia. They do need the consent of their parents. So this is why I bring up slippery slope. Once you stress that a person has a right to die, and you then further say that there's a certain level of autonomy that must be respected, then you're going to have to say, well, why is that autonomy only respected for terminal illnesses and not for chronic illnesses, even something to the degree of depression? I'll leave you to work that out. Now, if a person, for example, is in pain and they seek a level of morphine that will reduce their pain, but it is understood that at this level of morphine it'll also hasten their death. Is that euthanasia, even underneath that rubric? It is not, because if you remember the principle of double effect, it is foreseen that the individual will die sooner because of this. It's proportionate. The risk of death and the risk of not being in pain are the same. And the reality is that the person does not die from the actual reduction of pain, but from the medicine that was trying to reduce the pain. So under the principle of double effect, it would not qualify as euthanasia. I just simply want to bring that up because oftentimes it's a question individuals have. This brings me to the last few things that are being much more philosophical about suffering and death. Rabbi Heschel, Jewish rabbi, once said that if a person has not suffered, what could they possibly know? Which means that it's a very important thing in life. Now, it sounds kind of odd on the surface, does it not? Because we tend to want to reduce sufferings and increase joys. But that makes us think that joys and suffering are sort of the equivalent of pain and pleasure, and they're not. Life is full of pain, and life is full of suffering. It's also sometimes full of pain, but it's full of suffering, and it's also full of joy. These things are not the antithesis of one or the other. As a matter of fact, Viktor Frankl, the neurologist and a Holocaust survivor, he wrote a book, Man's Search for Meaning. So what he said was, in a syllogism, that he believes life has meaning, that he believes that suffering is part of life. Therefore, he believes that suffering has meaning. So in many ways, suffering is a sign, represents something other than itself to a knowing power, which draws one of us to the other. So it reflects our human conditions, quite frankly and quite honestly. And when one does suffer, it draws another individual into them, into their suffering. That could speak depths to who we exactly are as individuals, which brings me to the last point I'd like to make. There's a 20th century French existentialist. His name is Gabriel Marcel. And what Gabriel Marcel tried to do was to make a distinction between problems and between mysteries. So don't think of mystery as a whodunit, but his issue is that when we treat mysteries like problems, then that's where we kind of go astray in our thinking and our reasoning philosophically. So the way that he would say it is this, is that a problem is something that can be systematically addressed. So it could be a broken bone. It could even be a cancerous tumor. A diagnosis is made, and there's protocol on how to approach it. And whether or not there's actually an answer in the end, an answer could be done that said if we do this, then there will be at least some sort of wellness and health afterwards. It's the same way that we'd have a problem with our car. If it was making a particular noise, we'd go to a mechanic, and the mechanic would look at the issues, determine what the problem is, and then have a systematic way, conceivably at least, to address it. So with a problem, we're always in front of it, right? And it's always something that we can analyze. But mysteries are something entirely different, right? With a mystery, there's no distinction between what's in me and what's before me. In other words, we're enveloped in this. And it can only be experienced. It can't be analyzed. And you're never seeing a mystery from the outside. So human persons are a mystery. Death is a mystery. Illnesses and sufferings are a mystery. Joy is a mystery. These aren't problems to be solved. They're mysteries that we are enveloped in, and all we can do is enter into the experience of these things. Again, there's no distinction between what is in me and what is before me. And according to Marcel, where the problem literally arises is when we treat the problem as a mystery. We treat the mystery as a problem. So just keep it in the back of your mind. It's something to reflect on. I won't speak more on it, but nonetheless, in terms of what we're speaking about, whether withdrawing care or withholding care, or even just the experience of dying, and particularly the narrative competencies that we're trying to do, whether or not we're medical professionals, whether we're going to all be patients at some point, and we're all going to have this experience. So this is just a way for us now to start cultivating our life review prior to the time where we actually will do it in a real situation. So thank you for listening.